Hey.
If you'd like to ask questions of Dr. Davey and Dr. Newberger. Martin, Siobhan, will she need a microphone? As you see, we've got cameras here for our PBC members who can't join us all around the country. Hope this video will come out this time and they can share this with us. And what's equally as important is what the doctors are saying, but the questions from you, other people around the country will want to know the answers too. So please feel free, and Siobhan will come over to you with the microphone. Anybody got questions?
Yes. Can I talk to Dr. Newberger, please?
If you'll talk to you, yeah.
Firstly, I was involved on a trial drug, ADE SD4.
Yeah.
I've had no comebacks as to how successful or unsuccessful that was. And my second question would be, you showed that the certain areas were more prevalent to PBC across the world. On a global thing, could that possibly be linked to dietary or environmental things? You'd mentioned water, but could there be other causes for that? Has anything been looked into in those areas?
The answer to your first question, I have no information as to whether N-acetylmethionine has been of any benefit. I can ask them to let you know if they have the analysis yet.
Can I come in on
Yeah.
I am on arimethionine. I was put on the trial drug 3 years ago in December, at which point, sorry, Tilly Hale, one of the Newcastle contingent. 3 years past June, I was told I would need a transplant within months. 3 years in December, I was put on ADE-S4 or arimethionine. I have actually been on arimethionine ever since. I don't know if you are still on it. No. I was kept on it because the drug company looked at my results and were very pleased because my bowel responses were good. So I am one of a small number who, under Professor James, are actually continuing on the drug. Now, 3 years on from that trial, I take Urso and arimethionine. My quality of life has certainly improved. I don't know what the actual drug company is going to come up with, but certainly for some people in Newcastle, the results are being very encouraging. So, I'm only interrupting there to give you that point because it is of interest, obviously. Okay?
Thank you.
So, I mean, I don't know the Birmingham analysis that you've heard, the Newcastle view. The other issue is whether, I think the first question is, is the variation in the prevalence, is that a real one, or is that because people are more attuned to picking it up? And that is an issue that we don't know. We've recently seen 5 or 6 now Asian women from the West Midlands who've got PBC. And when we talk to doctors from India, they never ever see PBC in the Asian community. Now, we've argued and discussed whether that's because they're not used to thinking about it or because it isn't there, and there's no real way to answer that. And we've suggested that it may be that coming to a higher incidence area, they are more likely to get it. But whether it's nutrition, whether it's dietary, same thing, whether it's nutrition, whether it's environmental, whether it's something in the water supply, people have suggested that it's a higher incidence in urban areas than rural areas, and other people have come up with papers equally convincing saying exactly the opposite. Because the other issue, which I didn't really allude to, is it's much more common in women. For every 1 man with PBC, you get 9 women. The disease in men and women is exactly the same. So why there's that difference, again, isn't clear. I'm sure that's giving important clues, but we're not clever enough to deduce the observation from that.
Thanks. Elvira, you had a question.
It seems that many PBC patients have kidney or bladder problems, and I'm just wondering what the connection is, and also whether nephrogenic diabetes insipidus, is that what it's called, is connected with, is it a common complication in PBC?
Sorry. No. The answer to your first question, the second question is diabetes insipidus is not. I've seen a couple of people with diabetes insipidus and PBC. There are other diseases that are more common. The question about urinary tract infections is much more interesting, and a great deal, I think, depends on whether you live in Newcastle or London. If you live in London, they say that there's a very strong association between recurrent urinary tract infections and PBC, and Andy Barrows at the Royal Free's done a lot on that. Again, the Newcastle people have done the same sort of work and come up with the fact that, yes, people with PBC are more prone to get urinary tract infections, but no more than any other person with liver disease from any other cause. So I think people with women in general, for obvious reasons, tend to be more susceptible to urinary tract infections. People with liver disease tend to also be more susceptible to urinary tract infections, but I don't think it goes further than that. As I say, there are many other conditions that are associated with PBC. As I mentioned, thyroid is just one, and part of the reason why I think it's worth coming to see the doctor on at least an annual basis is that he can screen, or she can screen, for those other conditions which may be developing and can be treated early. And I guess that's partly why Dr. Dave is here to talk about osteoporosis, which is one of the conditions, but there's several others that one looks out for when you come to clinic.
I've just noticed that I come from Ireland, and many of our members there seem to have serious kidney problems, and in fact can't have kidney transplants because of the PBC, and are having to go on dialysis. So I don't know whether it's just coincidence or whether there is a connection.
There is a small increase in glomerulonephritis in PBC, but it's very small usually. Certainly without... so in general, it's not a major increase in risk, but there is an increased association. But with renal disease, it tends to be relatively small overall.
George, wait, hang on to the microphone, thanks, George.
I'm from King's College Hospital. I'm under King's College Hospital. I'm from the South East Group, Joan Heaton. I would like to ask both of you really a question, is that I'm on Urso 3 times a day. So I take my Urso TDS, and I'm on calcium twice a day, so I take that 7 or 8 in the morning and then about 6 at night with my evening meal. And I'm taking vitamin tablets as well. Do I take all these tablets together, or am I doing the right thing, taking them 3 times a day and spreading them out? Because I take evening primrose.
What does your doctor say, George? What does your doctor say?
Well, I don't really ask. I don't know. At first, my doctor at King said, "Oh, you're taking them at night, are you, Joan, the Urso?" And then I said, "No, I'm taking them 3 times a day." And he said, "Oh, that's all right then." So I don't know whether you prefer people to take them at night or 3 spread out or not. I'd just like to know. And also, I crush the calcium tablets up. These won't cause kidney stones, will they?
Right. If I could just concentrate on the calcium and bone side. In general, you take calcium supplements in the evening, not in the morning. They're much more effective taken in the evening for a number of technical reasons. They have a much greater effect at preventing bone breakdown. So that's the first thing to say about calcium supplements. If you're taking a lot of calcium, you can't take them all in one dose at, say, 8 o'clock at night, so you can spread them out through the evening. And that will be more effective than taking it in the morning. As far as any vitamin D is concerned, if you're given that, it doesn't really matter what time of day that you take that. I'm not aware of any data, though I could stand to be corrected by Dr. Newberger, that any of the drugs that you use for the treatment of primary biliary are going to improve calcium absorption if you take the calcium with those drugs. As far as breaking the calcium up is concerned, fine. That has no problem there. And as far as the formation of kidney stones in people with primary biliary is concerned, I would love to see somebody who's got one, because my main aim in life is to get the urinary calcium up to a reasonably respectable level. One of the ways that we measure whether people are taking enough calcium is to see how much calcium is coming out in the patient's urine. And in many cases of primary biliary that I see as first off, the amount of calcium in the urine is unmeasurable. So I load the patients up, and eventually I can get the urinary calcium somewhere near normal. But in primary biliary, I've never got the calcium anywhere near what you might regard as a toxic level. And even in patients who've got ordinary osteoporosis, if they're female, I've never ever induced a calcium stone. Males are slightly different. You have to be a little bit more careful there, but the art in primary biliary is looking at the urinary calcium level.
I mean, I think with Questrone you have to be careful because it can bind to other drugs, and it's best not to take other medication with your Questrone. As far as I'm aware, doesn't interact with other medication other than Questrone. And although it's recommended to take 3 times a day, in practice it's a bind to take 3 times a day, and a lot of people will compromise by taking it twice a day. It is recommended as 3, but in practice a lot of people take it twice a day. Yeah.
It's not better in the evening.
No, I'm not aware of that, no.
I think we sometimes say that to people. Sometimes taking Urso can make you feel a wee bit queasy. So a lot of people say the last thing at night before they go to bed, with a glass of milk or a biscuit, they're in bed and they don't feel that queasiness. Anybody else? Oh, good. Chat over there, Siobhan. He's a man, he's unusual.
Well, I'm Bill Dingle from the Norfolk and Norwich Liver Group. I don't have PBC, but my wife does. But she thought she's the secretary actually, but she thought it was much better to make me suffer to ask a question other than her having to get up. So anyway, the question is actually from our group, from Ruth Perfit, who's our Livewire coordinator, who you may well have heard of. She would like to know whether the PBC members will form part of the study group for the research purposes.
For our own research.
For our own, yes.
We haven't been asked, but probably if we're asked, yes, I'm quite sure that some of the membership would be happy to.
Thank you very much. Thank you.
Yes, this lady here, Siobhan.
Dr. Newberger, what is your opinion on the shunt treatment for esophageal varices?
I'm absolutely sure there's no hidden agenda to this.
I'm due to have it done next week.
Yeah. I mean, like everything else, it has its place. It has its... Unfortunately, life is a matter of compromises. And in an ideal... And with PBC, with liver disease in general, it's not an ideal situation. A shunt has its pros and cons, it has its risks and benefits. And like with any treatment, one has to weigh up the risks and benefits of shunts against the risks and benefits of other treatment. not having the shunt or having the alternative treatment. And I think it's hard to generalise. It's an extremely effective treatment in the right place. And I mean, we can talk later if you wish, but when used properly, it is a very good treatment, but it's not for everybody every time. I wouldn't advise everybody to have one. But for some people, it's extremely successful, and it's a matter of using it for the right person at the right time and keeping. And it depends so much on the clinical situation.
Okay.
I'm sorry not to.
This lady here, trouble, Adillion.
This is a question for both of you, really. I have to say, I'm past my sell-by date, so I'm on the HRT, and I do have a few problems now and again because they keep changing them due to budgets. So, with nothing else better to read, I had a look through the drug book, and it said, Urso, not to be taken with oestrogen. Could you explain, please?
It also says in the old leaflets that it's bad for liver disease as well.
Everything's bad for liver disease.
I think all drugs have got pros, all drugs have got cons and side effects. I think that with HRT, I've got no doubt that the benefit, for the vast majority of women, the benefits of HRT outweigh any risks. And we do get a lot of people pre and indeed post-transplant asking about HRT, and other things being equal, if there are none of the absolute contraindications to HRT, then I think if people can tolerate the side effects, it's extremely good. As regards Urso, I'm not aware of the data of interactions with Urso. The problem is with all the datasheet compendia, whilst I think it's extremely helpful for people to get all the information and make their own mind up, very often they don't tell you the evidence on which that advice is given. Estrogens can affect the liver. They can make you more jaundiced. And that's why one of the drugs that's used for itching is a drug called stanozolol, which is very effective for itching, but it makes a vast majority of people with PBC deeply yellow.
It didn't say it was a side effect, it just said not to be used with. And I wondered if it was a chemical reaction between the two that might occur in some brands and not in other brands.
I'm not aware of...
I'm not aware of this either.
I'll find out.
We shall need... I think that one of the things that we have to say is a lot of the drug companies are very careful, and they tend to put in every little, dot every I and cross every T. But it's certainly not something that's hit the mainstream medical press.
No, it was under Urso, not under... And there were only two drugs, it said, not to be used with. And the other was cholesterol-lowering drugs.
I'll find out.
Then you let us know.
Who makes it?
Thames.
He's listening, you can write.
We're sisters and we've both got PBC and we are both on HRT. We have been taken off the tablet form and put on the patch, which doesn't suit either of us. We're getting irritation on our legs and bottom from the patches, and I was wondering if what you think of the tablet form. Is it better than the patch?
Well, personally, I always give the patch. I find the patch has far fewer side effects, particularly in terms of breast. I mean, in terms of my general HRT practice, the side effects that I get most frequently are pain in the breast, abdominal swelling, and headache. There are lots of others, but those are the top three. And if I lower the dose by means of giving a low-dose patch, the side effects are far fewer, and I get the effect the effect on the bone that I'm after. One of the problems about HRT, if we're looking in the wider role, is what's its effect on things like heart disease, Alzheimer's, and so on. And most of the research there has been done on oral drugs, a drug called Premarin, because that's the one that's been around for the longest time. And I guess that with the transdermal patches, we don't know the answer to that unless we extrapolate and say that one estrogen is much like another. But one of the interesting things is, you probably have read in the newspapers recently that there's been anxiety about clotting on HRT. And in the paper that came from Oxford about this, one of the interesting things was, if you'd read the small print or the small tables, the incidence of clotting on transdermal patches was not actually statistically significant, whereas it was on oral. So I tend to use the patches all the time, and I mean, it suits me very well.
We hear that PBC goes in stages, 1 to 5 stages. How do we know when we've gone from one stage to the other? Is it through more symptoms, or what happens?
The stages you're talking about, I think, are the histological stage, where you go from 1 usually to 4. There are about 4 or 5 different classifications. Different pathologists like to get their name up in lights. It's their only opportunity. And where 4 is cirrhosis. I personally don't think that the staging is terribly helpful, because if you look at people who come, say, to transplantation, you don't necessarily have to be cirrhotic to need a transplant. Also, it's very patchy. And again, we don't do this until the liver's removed at transplantation. But if you biopsy the patient in several different places in the liver, you can show early stage 1 or stage 2 in one area and an established cirrhosis in another. So I personally don't think, in practical terms, it's very helpful. Clearly, if you've got a cirrhosis, it's likely to be more severe than if you haven't. But the clinical conditions don't correlate terribly well. And I think personally that to use those stages is not very helpful in clinical things. It's useful sometimes as a sort of shorthand when you're saying how different people compare. But I think that's its prime use rather than anything else, yeah.
There is one liver unit in this country who don't do biopsies unless they absolutely have to. And I'm quite lucky because I haven't had a biopsy. They don't do it where I go. So, the stages mean very little. Yeah. Early to mid PBC, it's how you feel, it's important how. Right, we're short on time. Any quick questions?
I've just got 2 questions. The first one is, assuming that there is maybe a trigger that actually triggers off the disease at some point in your life, has it ever been looked into whether the hepatitis B vaccine or booster has possibly been a trigger point? And the second question is, do you think it is the best option to go for a liver specialist centre on your checkups, or should you, if you've only got the local gastroenterologist at your local hospital, should you stay with them?
I think, can I answer your second question? There's 2 things about going to a specialist liver centre. Many district hospitals do not have up-to-date information through no fault of their own. But secondly, coming to a larger centre, they want to know about us. It's a 2-way street. We want to have the best medical attention, obviously, but these very, very clever hepatologists won't find out about PBC until they get our numbers together. You heard Dr. Newberger say earlier that we talk about trials with 200 people. It would be nice if he had 1,000 people with PBC. I'm sure his budget would not allow that. But that's the only way they're going to know about us, if we come to these large centres. That's
the
my opinion.
downside is when you go to the large centre, and this has been my experience, I've seen a different junior each time I've been, and you know, they're just reading through the notes new when you walk through the door. When I go to my local, see my local consultant, it's him I see each time. So you build up a relationship.
Many people come to a large liver centre, as you see, we see the junior. The junior is always reporting to the consultant. The consultant always knows. But also you can come to one of these hospitals, say once a year, and go to a local hospital every 6 months and have a consultant from a liver unit oversee what's happening. That's possible also. It's also a good compromise. But the first question, have time to speak.
I don't know of any evidence that that's the case. I think one of the problems with PBC is that the vast majority of people are extremely well, and a significant number get picked up on routine blood tests. And it's interesting that when we looked at, this is when I was at King's, we looked at the male and female to see how they presented, and women tend to present with itching. And what was interesting was that the premenopausal women had less itching. The premenopausal women had more itching than the postmenopausal women, and the men had even less. But we found a significant number of the men who'd come up from, they'd been on health screens or Bupa screens, and they'd found to have abnormal liver tests. And after they'd been attacked several times for being secret alcoholics and denied it, then they got referred on. And so I suspect a lot of people are getting picked up that way. And equally, it may be that having the vaccine or coming across a doctor coming in for an operation for a DNC or whatever leads to the diagnosis rather than the other way around. Having said that, I mean, I have seen I remember one woman I saw a long time, shortly after I arrived, who presented, which I'm sure was acute PBC. She was unwell with a bit of itching, and she was mitochondrial antibody positive, and I didn't know Colette then, but I didn't biopsy her, and I deeply regret it, because I'd love to know if she had PBC. Everything went away on no treatment. I just followed her up, and her itching got better, she felt better, her blood test went back to normal, her mitochondrial antibody disappeared. And what I'd love to know is, in 10 years' time, will she get PBC, or did she have an acute infection and get rid of it? And if she'd been susceptible for whatever reason, she might have gone on to develop chronic disease. I'd love to know what happened to that girl, and I regret I didn't biopsy her, but I couldn't really justify it, so I didn't.
Okay, we've got time for perhaps one more question. The lady from Ireland over there. Wait till the microphone comes. Sorry, Siobhan will run. She's healthy.
Is fibromyalgia a side effect of PBC? Or is fibromyalgia a side effect of PBC? Or is there an unknown connection at all?
There are some. I think it's difficult. Fibromyalgia is a sort of difficult term to define. And I think there are a number of factors which may make people, there's some conditions which may be associated with PBC that may give rise to a fibromyalgia type syndrome, immune complexes or maybe or whatever. I think it's difficult to be sure because what one doctor may call fibromyalgia, another doctor may call something different. And therefore, it's until you can define precisely the terms, it's hard to say, yes, there's an association, no, there isn't. I don't know if you've got...
Well, I think the important thing to say about fibromyalgia is that it is a well-defined syndrome. And if you just have aches and pains, that's not fibromyalgia. There are the well-defined places you've got to have pain, well-defined parts of the body, and you've got to have it on both sides, and all sorts of things. So you mustn't run away with the idea that every ache and pain is fibromyalgia. It's a well-defined syndrome. And the well-defined syndrome that is defined as fibromyalgia in the patients that I just so happen to pass through my hands with PBC, the patients haven't had it. But then I don't see many cases.
Well, it has been diagnosed by a rheumatologist and confirmed by a professor of rheumatology.
You should know what he's talking about. Yes. I mean, he will have made the diagnosis, but I'm not aware that it's commoner in PBC.
All right, thank you. Could I have a second question very quickly?
Yes.
Something that keeps going through my mind, and it mightn't be of great significance, but I'd love to know, is there any problem in people with rhesus negative blood having an availability of a liver if and when it is needed?
Can I just say to you, Anne, the chap who's actually filming for you is rhesus negative and had his transplant last year.
Did he? Yes.
Yeah, we found a liver for him, no bother.
Well, you see, it's in Ireland we have almost 1,000 women infected with hepatitis C, and these, if the women were to die, these are useless livers, if you'll forgive the expression. But and of course, these are also women who will be needing or may be needing transplants.
When you're looking for a donor, the important thing is the ABO and not the rhesus. Right. And so a rhesus negative recipient can receive a rhesus positive liver. It's the ABO that's important, not whether you're rhesus negative or positive.
All right, thank you very much.
Okay. Right, if you're all happy with that, you can, I'm sure if the doctors are staying for coffee and cake and things, you can chat away to them. I would just like, if you would indulge me for a few minutes, Mr. Dingle there preempted me. For those of you who don't know, we've made it with our research funds. We now have £80,000. Okay? Yourselves, you all contributed. We've started phase 2. Norma's come in with a cheque today. So phase 2 has started. We're going to go on, keep on going. I'll say to you again, Sarah Feidler, you'll see outside, she's in her uniform. I won't ask you to stand up, Sarah, but can you stand up? Isn't she lovely? Now, Sarah has experience with PBC because she's getting married to my son, so she knows quite a lot about it. And she will give you, I'm sure, good advice. Please don't expect personal diagnosis because she can't do that. She will give you help. I'd like to thank Martin and Brian for coming down from Scotland and filming this for us. I think they've done a great job, and thank you very much, chaps. I'd also like to thank Dr. Davey and Dr. Newberger. Tess has got something terribly nice. It's a hepatoxin, I have to tell you. We all believe in it, and I really, really hope you do. I hope your isolation has been taken away, you've got more information, you've found some friends, you've got me on the phone, you've got coordinators, you've found each other. None of this would have been possible if 6 years ago Marilyn Robinson hadn't sat down and thought about the situation she was in and how other people were suffering. And she worked very, very hard to help many, many people in this country. She's been an inspiration to me. She's behind me 100%. I would like to say a big thank you to Marilyn from all of us, Marilyn. From the Trust, the BLT, we've got our new support group manager, Susan, and stand up, Susan, hello Susan, and Kate Granger as well, so you can chat to these girls afterwards. Thank you very much everybody, and go and enjoy your tea.